Okay, welcome colleagues, and thank you for logging into our very exciting eco session today. My name is Francis Ochena, Project Manager with ASLM, your moderator for the day. Our session today is a bit special. We will go for more than an hour, like we've always done, but it is going to be 1 hour, 30 minutes maximum. We will have the two presentations, one done in French and the other done in Portuguese. So kindly get to the language of your choice in our interpretation channels so that you do not lose out on anything. Our session slides will be made available to us, and of course join us through the chat so that you can participate. Questions or comments, counter comments can only come through the chat. As we work towards realizing our vision as ASLM, and our vision is a healthier Africa through access to quality lab services for all, we are very intentional. And we do not only have structured in institutional strategies, but we also purposively propose and implement multiple projects and programs that contribute to the realization of our vision in alignment with, of course, the interest of our partners that we work with. Building on the lessons during the COVID-19 pandemic and the large outbreak of Ebola in West Africa in 2014, there is recognition that achieving an outbreak-ready status under the international health regulation by countries is really key and requires integrating efforts to strengthen core public health functions, including diagnostics. In today's session, colleagues, we share the implementation experience of our Resolve to Save Lives funded project. The project is stepping up lab readiness capabilities for clinical and public health decision-making in Africa. And so in reviewing this project, as we're in its second phase, and the second phase is coming to an end, we'll be focusing on what has been done in improving detection, surveillance, and response to some selected priority diseases, both in centralized and decentralized testing settings. And we'll get experiences from 2 countries out of the 4 countries that we're implementing this project, and that is Sao Tome and Principe and Burkina Faso. And so in sharing these experiences, colleagues, our speakers are 2, and we'll have the first speaker from Burkina Faso. And our first speaker is Mr. Lenli Lompo. And Lenli is a medical biologist specializing in molecular biology and genetic engineering. He is currently assigned to the medical division in an in vitro diagnostic test unit of the Ministry of Health in Burkina Faso. Mr. Lenli is responsible for managing a lab network data, coordinating capacity building activities, and also supervises quality biological analysis. He is also the acting national focal person for the Resolve project in Burkina Faso. And our second presenter is Yadlin Sacramento Sequeira, and Yadlin is a coordinator of the National TB, HIV, and COVID-19 Reference Laboratory in the National Endemic Center, Ministry of Health in Sao Tome and Principe. So colleagues, join me in welcoming first Lenli, and then Yadlin will take on from there. Lenli, over to you.
Thank you, everyone. Welcome to this session of experience sharing for Burkina Faso on the strengthening of the national network of laboratory effective diagnostics You need to note that this work has been produced by a team of the laboratory directory composed with Dr. Key Eve and myself, Lombolenli. My presentation will be as follows. First, we are going to give the presentation of the network for Burkina Faso, which will be articulated in its situation on the analysis based on the evaluation report. And secondly, we're going to talk about national list of essential analyses, which faces a national list of analysis essential, and then there will be the presentation of development in vitro essential. And thirdly, we're going to talk about Resolve project in its different activities and carried and we're going to share the result of impacts, and then we're going to talk about challenges encountered. And lastly, we're going to talk about lessons learned. We should say that the national network of laboratories in its structure, we see the creation in 2014, which was revised in 2024. And its Article 2 states that the national network of laboratories, public and private, for the prevention, detection, confirmation of infectious diseases in public health. This national network of laboratories is composed of public and private laboratories classified as follows. A central level, which is composed with the reference national laboratory, which is called 9, and then we have national laboratories, and these 3 laboratories respond to the national, and the intermediary or regional, where we find the hospitality center and the regional center, and finally the laboratory of new peripheries, where we find the new medical centers and surgical areas. What can we say of the mapping of the national network of laboratories? We can say that this mapping has been realized in 2022, which consists with 255 laboratories at the national level, with the pyramid scale at the 3rd and 4th level. We have the central level with 12 laboratories, and the 2nd level, which is the intermediary level, with 71 laboratories, and the 1st level, which corresponds to the peripheric level, with 172 laboratories. We need to note that these laboratories are publicly characterized military veterinaries as well. What can we say about the situation analysis of the laboratory network in terms of strength and weaknesses? In terms of weaknesses, we can say that the national network is very well structured and functional, with a good collaboration intra and extra sectorial, which means between different sectors, environment. We also have a professional team qualified with competencies in pharmacist, biologist, and we also have a good partnership to mention ASLM, WHO. In terms of weaknesses, we can say that the national network of laboratories depends on its financial partners, and we noted that there is a heavy administrative responsibility in terms of public health. What can we say of the national list in terms of care level? The LND created in 2009 faced essential analysis at scale level. In its list, there was different goals, and this list faced a weak application and an evolution of tests, to mention the biomolecular tests, and that needed a revision in December 2023. We're talking about essential tests. And it says essential and general test of diseases. And we have to say that these two tests are possible at the structure level, community without laboratories, to mention CSPs, as well as the care cabinets. We have to say that these two lists are possible at the level of sanitary, where we can find laboratories or isolated laboratories which are not exceeded to the clinics. What can we say about LNDE interest? It's allowed the country to do resources mobilization, and also it also allowed the planification of different activities and to mention how and where to implement those activities. In terms of leadership, with the laboratory director, we managed to coordinate the activities and make the decisions to define our priorities. What can we say of the diagnosis of priority diseases? We can say that our health system is organized on a pyramid scale, which has three levels. The first level, which is composed of the village sector and the district sector, and the second level, which is the regional, the third one, which is the central level. We can say that the national network of laboratories works with the first level, which correspond to the training structure without laboratories, and the laboratories of CMA, which respond to the first level of reference for the districts. And the second level here, we have laboratories in conformity with the national structure as well as private structures, which respond to the second level. And at the third level, we have at the national level of laboratories for a total of 255 laboratories throughout the nation. In terms of justification of accomplished project, phase one, which was to reinforce the system of quality management and the strengthening of transport of samples. We can say since the Ebola virus, our network faced a strengthening of capacity, and also there was a weak level of preparation to stand the different diseases. We also noticed the poor quality of laboratory services. And in 2019, we had to accompany Burkina Faso to have a quality and in 2023, we have the reinforcement of preparation to riposte. What are the activities that we realized around the first phase of reinforcement in Burkina Faso? In first place, we have the trainings for a basic system of quality management, the accompaniment of audit in laboratories, internal and external, and accompaniment for a management system for quality of these laboratories, which was done in 2021. And after COVID-19, we noticed a reinforcement among us the quality and also the biosecurity and the evaluation of laboratory risks, transportation of biological samples, and above all, the quality management of rapid tests. We also had as activities in 2020, the evaluation of diagnosis with the tools for the COVID-19, and there was also the centers for COVID testing. And there was also 35 laboratories on the evaluation program and the update of mapping data with the capacity of 55 laboratories which were realized. On the second phase, Burkina Faso was beneficiary, which consists in strengthening laboratory preparedness for clinical and public health decision-making in Africa, of which Burkina Faso is a beneficiary. So the objective was to strengthen the laboratory network's preparedness for early detection response to epidemics. What are the priority diseases selected for the referral system? We can say in Burkina Faso, the priority diseases selected were FHV, which is dengue fever, which is the priority disease in Burkina Faso. We have three. We have the dengue fever, and at this level, we choose dengue, which was, and then we have a bacterial meningitis. And finally, we have rotavirus, diarrhea, and diseases. So the priority diseases available of RDTS1 health approach to see the availability of RDTS. And finally, we also consider the approach here. You can see two pictures. The second picture shows the first authorities of the country for their commitment to the second phase of the project. And we have the General Secretary of the Health Ministry, and he was with the Director of Health Products in the country, as well as the Biological Medical Director, with the first ASLM director. And the first picture shows the stakeholders of the launch of the project by the adoption of the plan. In terms of selection process for priority diseases under the project, we can say that the ASLM is working in conformity with the priority diseases, and the NLD has different tests according to the three priority diseases as mentioned earlier. So we can say these are possible tests depending on the sanitary infrastructures. If you check the first table, you realize that the RA, which is in connection with the dengue, is possible at all level to mention the peripheric level, which is the area with laboratories, and finally the new level, which is the central level, which is the ALNR at the same level. So all these are possible at all level of the sanitary scale. And this one is only possible at this on the second table in connection with the PCR. These tests are only possible at one level, LNR, and at a central level. For the bacterial diseases, for meningitis, we have the tests that are possible from the coloration level at the central level. We can also do microsounds. We can reach that at all level. Talking about viruses, we can do the speed test at all level of the possibilities, and the confirmation test for this case is possible with the action what were the priority and site. And site selection criteria for those diseases. Through the evaluation, the first one, we had 37 sites in total, which were identified. And in the different 7 regions, 23 districts, which had 4 laboratories at the national level. In terms of research, we have 1 laboratory which was involved. And at the level of district hospitals, we had 24 labs. And at the CHPS level, we consider the evaluation of sites as criteria of selection. We were based on the sentinel signs peripheral level and also considering the security challenge zone. And all the 8 SPS were the sites where we experienced the accomplishment of the first disease. And this was just an experiment to see the capacity level of those structures. Key activities implemented as part of the Resolve project in Burkina Faso. We have the training for evaluators and users, evaluation of sites, and we also have printing and dissemination of the L&D at all the level. And we can also note the development of SOPs for the 3 priority diseases with the support of the coordination activities of the sample and the transportation of samples. All this was done in 2024. And for the year 2025, we realized simulation exercise to assess detection capability based on SOPs. We also did the equipment of sites with a region to detect the 3 priority diseases, dengue, rotavirus, and the meningitis. Well, in general, these were the activities we realized in the second phase of the project. We have pictures that are showing the key activities implemented as part of the Resolve project. The first picture shows the training of evaluators. This was in April. On the third picture, we have the exercise which was done in May this year. And the fifth picture, it shows the repetition or the dissemination of DTR of the sanitary training. Dear participant, what was the main result and impact of project? In terms of results, we can say that the project allowed to strengthen the skills of health workers in the country's 37 sites and 6 health regions. We also have at our disposition LNDE documents at the 3 levels and the preparation of the country to face different challenges. In terms of evaluations, we had 2 evaluations. To mention LabNet scorecard, which was realized in 9 stages, which gave us a high result between 2019 with a 2.25 and in 2025 with a 3.60. We can see the growth of the result. And as for the 2017, you can see from the indicators that in 2023 to 2025, we didn't have a great growth of the result, but that can be explained in 2024, where we had to change the system. Well, listen, 2017 was just based on the Ministry of Health. Here we have a presentation that shows the evaluation of the first phase of the project, which works on the DTR evaluator. And we noted that there was a growth, a significant growth of its first phase to the second phase, and the level of structures. And we have the result of our first phase of the evaluation. The second phase was done in 2024, and Burkina Faso was one of the beneficiaries. And this had 37 sites which were realized, and we had the result of 46. We can say that this was the first evaluation which was analyzed, and the second evaluation was done, but the data was not analyzed, so we're still waiting for the final result. What can we say about collaboration with other healthcare sectors and partners? We know that there's collaboration with LabCoP in the implementation of its action plan and annual assessment and self-evaluation. The use of the laboratory mapping and collaboration with WHO of internal jet within the framework of support coordinating the activities. We also have the availability input in 3 levels of the health pyramid. We also noted the capacity building for peripheral health care providers updating the mapping of the National Laboratory Network and the structure of the Ministry of Animal Health and the Ministry of the Environment in a One Health system to allow a monitoring system of the project. And in terms of challenges, we can say that there was an establishment of a monitoring program. So we need to strengthen that program. We also need to update the quality structure to not be used at the peripheral level. There was also the capacity building for the areas without laboratories, but we started with the implementation of the first stage with 8 SPAs. So the updating of the mapping of the National Laboratory Network. What can we say about lessons learned? We have the accompanying by the authorities, support from all those involved in the project, to mention the partners, and there's also development and validation of SOPs for DTR approved for the 3 priority diseases. In terms of best practices, we can say that there is an availability of national RDT SOPs for the 3 priority diseases, which allows our actors to work considering the different accomplishments. And also, we can talk of simulation exercise to assess detection capacity for priority disease. This happened in 2025. That allows the country to identify the priority zones. And I can't conclude without saying thank you to ASLM, and through the project, they were with us throughout the preparation. And I cannot conclude without thanking our first responsible of the Ministry of Health, and in particular, which gave us a serious help to the accomplishment of this work. Dear participant, I am done with my presentation. Thank you for your attention. I don't think I said everything, but I'm available for questions. Thank you.
Merci beaucoup, Lenny. Excellent presentation there, providing a great overview of the work that was done, both in phase 1 and mostly in phase 2 of the Resolve project in Burkina Faso, providing us some clear rationale on the selection of the areas that they had to work with, but also highlighting some of the enablers and the challenges that that were faced during the implementation of this project. I will encourage us to continue sending the questions in the chat. Also, please make sure that you're on the right language channel, because we're seeing a few questions coming through in the chat related to challenges with interpretation. And then we'll deal with those questions at the end of the second presentation. So allow me at this point to invite our second presenter, Yadlin Sacramento. Yadlin, let me hand it over to you. Thank you.
We're going to make our presentation of our activities with the help of the project Resolve in Sao Tome to better the with the help to strengthen the system of transportation of the samples in Sao Tome. I would like to present to you the country profile of Sao Tome. So it's an archipelago which is located in the Gulf of Guinea in the Central Africa, in the line of the equator, and on the east of Gabon. We've got two islands, which is Sao Tome and Principe, with a total superfice of 1,001 square kilometers, with a population of 214,610 inhabitants since 2011. Now, in terms of monitoring the system of transport of samples in relation with the viral load for diagnostic of HIV, the first evaluation, we had a quorum, we had a score, we have a score of 1 on our first presentation. Now, the indicators are here. Which are selected. It was the rate of rejection in those essential testing institution, the level of rejection. Now, in terms of evaluation of the readiness of the service of diagnostic, we have two capacity. We've got we are currently in planning and also in the network of diagnostic. Now, what are our aim for this activity? We had as objective to help the operationalization to better the system of samples in Sao Tome. Now, during this project, we had activities which were planned, which is the meeting of contextualization of the government, of inclusion of the whole country, to support the personalization of the system, of the laboratory, and to help the system of transportation of the samples. Now, the specification of the recommended pathology, it was done through special diagnostic for the test in the country. It was equally we prioritize the pathologies of diarrheas, rotavirus, and we also had as our objective, it was to prepare for surveillance and to help in diagnostic the infection of HIV with the new diagnostic test for culturing the feces to diagnose HIV. And now those tests that could be used in those installation that has the labs. Now here is our calendar of implementation of our activities. We have as activity some of the activity, which is the disinvolvement of logistics for the transportation of sample. And we had as objective create infrastructure for transportation of samples in the first year. And we also had as capacity to strengthen and capacity building the labs workers so that they can accompany the transportation of the sample. Now, when it comes to capacity building, implementation of a system of communication, which was indicated for the second and third trimester, implementation of the structure for the transportation of those laboratory. Now, when it comes to capacity building of the people, we have the implementation of monitoring and evaluation to regularly check how the project is faring nationally. Now, in terms of activities done, we have the approved plan of work of the country for pathologies like dengue, Ebola, cholera, and meningitis. Now, realization of the situational analysis in validation of the transportation of the samples, translation of our training equipment, training of our lab technician and this agent which transport international samples, acquisition of equipment for different laboratories, and this process is still ongoing. Now, in terms of evaluation of our mapping of transport of samples, we have as our map, we've got in the peripheries, we've got intermediate, and we've got the private one, public, in a total of 21 laboratory. Now, our success, we've got national alignment of priority diseases as implementation. We also have personalized protocols of transportation. We also had capacity building for our technicians, readiness in the functionality of the infrastructure for the transportation of the sample. Now, our results and success, we have mapping the laboratory, capacity building of the evaluators and their certificates with ASLM, validation of the national strategy of development of the system of samples. We've got the validation of the national list of LNDE and certification of reference system of sample. Impact of the project in terms of capacity of testing, strengthening technical capacity, strengthening the surveillance, epidemiologic surveillance, logistics support, and infrastructure. Now, in terms of the prioritizing the pathology for transportation of the samples, we've got prioritized pathologies. We've got cholera, dengue, Ebola, Marburg, and meningitis. Our strategy to promote and develop the transport in Sao Tome, it's a strategy that will have from 2024 up to 2026. Now, the impact of this project, we have as an impact political alignment, integration with national infrastructures of health. We've got a rapid diagnostic test for quick response. We have a system of transportation strengthen of our samples so that we can do a quick rapid diagnostic of sickness. And then we've got confidentiality and privacy in our samples and quick response in our diagnosis. Now, we've got ongoing activity we still have. Currently, we have a capacity building of the molecular biology technicians, which we just finished this past weekend. Now, acquisition of motorbike for transportation of the samples. This is what we are still ongoing. Acquisition of technical equipment for the labs, elaboration and validation of testing of priority pathologies. Now, all those are the activities that we are doing currently. Our best practices that we can take from the support has to do with the cost of the map with to register all our centers of health and then to transport our samples, to elaborate key documents for our priority disease. We also have to form at different levels of our priority for diagnostic and also decentralization of our diagnostic labs. Now, what is the status of our project, of our work of integration national? We have as our aim engagement meeting with all our stakeholders that we have already concluded with different points, which is the support in operationalization and strengthening our transport of our samples, disinvolvement of ACOP, which is capacity building of the professionals, which we have concluded, operationalization of transport of our samples, which I have already said it's an ongoing, and the others that was cancelled. Our challenges and our future steps: to elaborate strategic plans of cholera, national algorithm to diagnose all those 5 priority diseases, capacity building, continuous capacity building of our health professional, training on our epidemiologic surveillance, plans of sustainability for our labs, strengthening our laboratory system for all the labs all over the country, acquisition of a diagnostic test for molecular biology, strengthening the priorities on those laboratory, even strengthening and bettering the system of monitoring for priority pathologies. About our lessons learned, we've got LabMap that is assigning all the centers of health. We've got documents, key documents for priorities, training or capacity building of our national technicians, supervision of our local testing places, rapid testing places. Now, collaboration with our partners and stakeholders of health. We've got, as a health, we've got the Ministry of Health. We've got installation of health institution, hospitals, TB places, districts, national centers. We also have World Health Organization, PNUD, and then we also have transport agents and logistic and representative of local community. Thank you. Those are our partners that we thank them very much. We've got Resolve to Save Life. We've got Diagnostics for All, ASLM, and we also have the Department of Surveillance for Epidemiology. Thank you very much. Thank you very much. Thank you very much. Thank you very much.
Obrigado. Again, another very great overview of part I have to note, because a lot has been done in the two countries, but we're sharing just part of the great work that has been done over the 2 or so years with support from this project. And of course, in collaboration with the Ministries of Health and other partners that are in the 2 countries that are presenting today, but overall the 4 countries that the project was being implemented in. And kindly continue getting the questions coming through. We have some interesting questions that we'll be dealing with. I want to just highlight that the Sao Tome presentation brings out very clearly the aspect of a structured assessment, ongoing assessment, to make sure that if there was gap in the beginning, either using your joint external evaluation results or the other assessment tools that we use as ASLM and other partners, then it is very important that once those structured assessments are done at the beginning, then you do implementation on your prioritized areas, then you do another assessment. And I think that came out very, very nicely here. So you do another assessment to see what the progress is. Of course, this high-level assessment is not going to take away the need to do the day-to-day monitoring and evaluation of your project implementation. So I thought that that came out quite clearly. I also need to note at this point that we really need to be prepared. We need to, so to speak, be combat ready. Because if we are not, then when we are hit, when we get an outbreak, we will have nothing else to do but go with the rudimentary tools that we have, because we still have to face the outbreaks with whatever form of tools that there could be in our toolboxes. So luck will therefore favor those who prepare, because then they will have better tools to work with when they have to face any war. And in this case, the bio wars that we do in the health sector. We have so many questions that have come through. Keep them coming in any of the 3 languages. We have colleagues in the background who will be doing quick translation and reposting them. So don't worry about whichever language. You can post your question in French, Portuguese, or English, and we'll get there. Now, let me get to our first question. And our first question is coming in from Christopher. And Christopher was asking, because part of the domains that came through from Burkina Faso, and I think also from Sao Tome, is that you wanted, in getting ready for any outbreak, but also supporting your routine individual and public health services provision, you needed to improve your specimen referral, because testing cannot be done at every level. You have to, some specialized tests are probably done in the more tertiary segment of your tiered lab network that you shared with us. So what were some of the specific interventions that you did to improve the sample referral network? And I will start with the Burkina Faso colleague. Is preparing to respond. Let me push the question to Yadlin. And Yadlin, just on the specific interventions that you've done to improve your sample referral network. I know that there is a bit of procuring motorcycles and a few other things, but just expand it for us. Some of the specific interventions that you did to strengthen your sample referral network.
So in terms of Sao Tome, so when it comes to Sao Tome, in terms of transport of samples, we had capacity building of our technician for transportation of those samples of reference. We also had capacity building of the evaluators to monitor the places of testing. With those testing, we also preparing the advocating with the agencies of traveling agencies so that they can also allow us to be sending our samples in terms of the country not being capable of chemicals for processing of those samples, capacity building of our technician for diagnosis of molecular biology in the country, and also we are in the process of acquiring the motorbike to strengthening the transport of our samples for some of the reference laboratory. So those are our capacity of strengthening the transportation of reference. Thank you.
Thank you. Thank you very much, Yadlin and team in Sao Tome and Principe. Can I take it back to Lenly if there are some additional areas that you may want to cover in terms of strengthening your sample referral, in terms of what was done, given the support that you are receiving during this project implementation?
Thank you for the flow. I can say that the second phase of the project allowed us to have sanitary trainings which happened in peripheric areas, to have sample collections and send them to the reference level, as to mention laboratories of same. So there's been procurement of cooler boxes, which allowed the actors on the ground to collect samples if needed, and to make sure that they are transported in good conditions. And at the Burkina Faso level, there's a department that is responsible of collecting samples and sending them to the destination.
Thank you, Lenly. Let me hold it with you, Lenly, now that your connectivity is working. And I get you the second question. And the second question is coming in from Sarah. And Sarah is appreciating the great surveillance and disease detection work that is happening in Burkina Faso. But she goes on to ask that you are bordered by many countries as a country. And the question is, do you have active transborder surveillance that is happening for priority diseases? Or are there existing collaborative efforts across neighboring countries with your country?
Thank you for the flow. We can say that at the transborder level, we have a collaboration in terms of health. We're in collaboration with our neighboring countries in connection with priority diseases identified in Burkina Faso. We have collaboration between health workers as well as the engagement with the RAS, which allows us to be in direct connection with the ALC vision.
Great, thank you. So I'll do this a bit early, but just to help me hold you again, Mr. Lenley, just a quick question on the implementation of this project. I know we have not shared everything that you've done, and we know that the project always has its scope, technical scope, the budget scope, and the time scope. So those are the limits that you can work within. But if you were to implement the project again, what are some of the areas that would be prioritized based on your learning from this phase that you've implemented this far?
Thank you. I can say that if we are to benefit for ASLM support on the project, we noted that in our results, Burkina Faso managed to identify the 3 species of new peripherics that ALNJ doesn't provide realization and experience the capacity level of the capacity, because we need to be next to the community where we need to be so that we won't miss any case of those 3 priority diseases. So we can say that we need to strengthen the monitoring to be able to monitor the capacity, and the accomplishment is well executed at the peripheral level. And also we need to train different actors at the peripheral level who don't have laboratories but are able to do the test so that we have a good result. We also have another area is to make sure that the LAND is available at all level of the structure so that the actors are very well trained and they can easily undergo the activities at each level of the structure. We had the phase of dissemination of LND at the sanitary pyramid, but there's also another activity that which is to build the capacity of the actors on the ground so that they can own what is ALND for the response to different outbreaks that we may face. We can say that currently in Burkina Faso, we only have 3 diseases that were identified, but there are many other diseases that are there and the project can consider. The 37 sites identified, we could have gone to more than 250 sites, but we limited ourselves at 37 sites because of resources challenges. So out of 250 sites, we only managed to cover 37, which is not even half of the number. So there's always something to win. And if the project is to be undertaken again, so we are going to take more and more of the priority diseases and many more other diseases that we could identify at the national level. Thank you.
Thank you. Thank you very much, Lenley. And I know that even if there may not be an extension, that's not what I'm saying. There could still be a phase 3 of the project, but just in case there isn't one, then we can still work with the learning from the 2 phases of the project to support us in scaling up the good practices that we did within the scope of this project to cover even more mileage, given alternative funding sources that may be available to Burkina Faso. Just a comment and a note for your response. Now, let me take it to Yadlin and team in Sao Tome. And I'll still take us back to the question around the border surveillance. And I know that Sao Tome is in the middle of the ocean, but we still, even if you do not have land borders with other countries, you're still accessible by other countries, but probably how it plays out there is a bit different. And we would want to hear from you what some of the strategies are that you're putting in place to make sure that you do cross-border surveillance and make sure that pathogens that are kind of outbreak prone should not get to Sao Tome and Principe, or if they do, they're detected at the earliest possible opportunity. Yadlin and team. Yadlin, if you're speaking, you're on mute. Thank you. You're now unmuted.
So in Sao Tome, in terms of our borders, indeed, we don't have borders. We don't share borders with anyone. But we have we don't have terrestrial border, but we have air borders. So now in terms of limitation, in terms of controlling the diseases, we've got surveillance team at the airport that control all the passengers. So that they can report or detect any symptoms. So now this surveillance is done in collaboration with the National Laboratory of Reference. Now, in this case, if we have any suspect of outbreak, we isolate the patient, quarantine the patient. Still there at the airport, we've got a place of isolation, of quarantine, and then we collect the sample so that we can see what pathology is there with this patient.
Thank you very much. And
in this sense, we would like to strengthen the capacity building so that we can increase the technical team that are doing this activity. We also need material to be able to accomplish these activities. Elaboration of procedures and directorate of the functioning of these activities of monitoring and surveillance in the airport and the harbors all over the country. I hope I have responded the questions. Thank you very much.
Thank you very much, Yadlin and the Sao Tome team there. Yes, so colleagues, keep the questions coming. We have about 5 more minutes to continue this discussion, and I'll give back some minutes to you if we can't exhaust everything here. There are some questions and comments coming related to the standard operating procedures for pathogenic organisms and others. And I'll want to take this and just summarize that because the question is what appropriate SOPs can be used for analyzing or deployment, if you have to deploy an SOP in the detection of pathogenic microorganisms. So I think it depends on what it is that you want to do with that sample, because you may suspect a pathogenic organism in a sample and you're just dealing with referring that sample to a facility that can do the testing. And so your SOP for referral will take that shape. What do you do? How do you do the packaging? Who does it? When do you do what, and all that? And of course, with the safety precautions and quality control. And the same applies to if you're going to do the testing in your own lab, in-house testing. Your SOP, besides the format that you will have agreed in your quality management system of how your SOP is structured, when it comes to the details of the how the testing is done, then it will depend on that particular pathogen you're suspecting, but also the method, the test method you're going to be using, because then that will determine whether you pipette 50 microliters, whether you then do the incubation, whether you then you just feed the sample into the analyzer. So the details will definitely depend on the method you're using, and then the sample that you're actually also using. And this will take care of the safety precautions, because if you're going to be doing an Ebola test in your biosafety level 3 lab, then the safety precautions when you're running that test should also be built in there. And so it is a general question that we can speak to very much at length, but I just wanted to provide that overview, and then I let the presenters deal with the other questions. And the next question that I am going to take to Burkina Faso team, and Lenley, if you have any other colleague who can support you, it's perfectly okay. You can alert them and we will let them be able to unmute and support you. But the question is, you spoke to having your national essential diagnostic list. There was a version that came out in 2009. And I think through this project, you've worked on revising it or editing it to the next version. And I don't know if it's version 2024 or version 2023. But the question that somebody is asking is, what is the level of implementation of the tests that you have defined in your national essential diagnostic list? Because you're saying tier 1 labs should be doing this, tier 2 labs should be doing this, and tier 3 labs should be doing this. And probably we are committing resources to make sure that those labs are capacitated to do those tests that are prescribed for them. But what is the uptake like? So is everything prescribed at every level happening that way, or some levels are doing less than they should be doing? And what are some of the reasons why that could be happening?
Thank you. To respond to the question, you want to know what's the minimum package of activities possible at care level, which means, is it the same test that we can use at all the levels? The minimum provided by LMD, the peripheral level, for the peripheral level, LND provided tests, rapid tests, which allows the peripheral level to realize, to accomplish the technical area, which is not, but the rapid test, if we take the intermediary level, which corresponds in our country to the SHARE, which is the regional hospital center, which is the equipment, which means with the diagnosis, and at the share level, we can accomplish all the types of diagnosis which were realized at the peripheral level, to just double check and confirm if the peripheral level has the credibility of the test and the precision of the test. And at the intermediary level, with the accomplishment of their work, they will confirm that what is done at the peripheral level is good quality. And at the central level, we have the antigenic, which is confirmed by the platform, which allows that there is a level which is a higher level to allow us to accomplish the confirmation of all those cases. So in brief, I can say that the LNDE uh, provides at each level of the laboratory what are the type of tests that we can be using. And in terms of capacity of the staff is very well trained, but it's also a matter of available equipment, and that's how I can answer by saying that the DTR can be uh, done at all three levels. And the rapid test can also be done at the LNR, which is the National Reference Laboratory, or else the LCR, which is the central level. Thank you.
Thank you very much, Lenley. And colleagues, we are almost coming to the end. We will not push it until 17:30 East African time, just in the interest of what we're used to. And so let me just hand it over to the Sao Tome team to just weigh in on the implementation of your NEDL, if it is already developed and launched. Is it being implemented at 100% level, or we still do not have that achieved? But as you answer that question, Yadlin, you can also then give us your closing remarks, because I won't come back to you again. So just you weighing in on how the level of implementation is of your national essential diagnostic list, if it is there, and then your closing remarks. Over to you, Yadlin.
The implementation of NLDL, unfortunately, we haven't started implementing, but we are in the process of implementation. That's what I want to say for now. But from the list that we have prioritized, we have some category of pathologies which are prioritized by us, like the case of typhoid fever, infection for HIV, in which deserve the decentralization of the test in all laboratory, in the periphery, intermediate, and even the central ones and the national ones as well. Thank you.
Thank you very much, Yadlin, and we'll take that as your closing remarks as well. So let me hand it over to the Burkina Faso team, just for your closing remarks. Lenley and Tim.
Thank you. I want to say thank you to ASLM through the project to have accompanied Burkina Faso in the consideration of the report against essentials outbreaks and the diseases that are mentioned with the 3 identified in the case of Burkina Faso. And with the Resolve project, we think we have reached our goals or our targets, but we're still available for the accompaniment of ASLM through maybe another phase, a 3rd phase of project, so that other structures that did not benefit from the capacity building or the technical advancement for ASLM. Thank you.
Thank you very much, Burkina Faso and Sao Tome and Principe. I will not forget to add the N Principe because you have 2 distinct locations that belong to the same country. Very exciting presentations here, and not in a very familiar language. I know people are asking, should it be in English, should it be the other side? But it is the same. We have interpretation services. And so when it is done in any other language, we still have the opportunity to get to know. And because if we do not, then we lose the opportunity to get to know what is happening in the other side of the world. And also, let me note that we'll see if we can translate the slides into English and Portuguese, the French one, and then also English and French, the Portuguese one, so that when our materials are coming out, you have all that is usable from your side. And we'll begin making the same consideration. All slides that are in English, we will make considerations to see if we can translate them into French and Portuguese so that our colleagues who are Francophone and Lusophone can benefit entirely. Again, as I said during one of my comments here, we need to be prepared. And we can only get to know whether we're prepared or not if we do a very structured assessment. And there are tools out there that we can use to make sure that we do assessments and know where we are. Sometimes you might think you're actually doing well when it is not. And then the results of those assessments can be used for very targeted intervention so that the few resources that you have can be efficiently and meaningfully deployed and get you the results that you're looking for. And of course, sustainability is key. Even when the project is coming to an end like this, we still then expect that there are some facets of sustainability that were built into the implementation that will continue even when the project is no more. So with those and from us, ASLM, allow me to wish you the very best of your morning, afternoon, or evening, depending on where you're joining us from. And also, again, appreciate that even when we were doing it in a very non-usual way of doing a 1.5 hours long session, we still have a good number of you logged in, because I know people have always been used to the 1 hour long session. So thank you very much, and looking forward to seeing you in our next session, which will be tomorrow and many more subsequently following. So bye for now and enjoy the rest of your day.